It's my pleasure actually to reintroduce Dr. Campbell to you. She is our speaker for today. She is an assistant professor in the Sue and Bill Gross School of Nursing. She's been a registered nurse for over 20 years and spent the first decade of her nursing career in the acute care setting, caring for complex patients. And she joined as faculty here at UC Irvine in 2018 and teaches in the Doctor of Nursing Practice program. Her areas of interest include geriatrics, health promotion and disease prevention, chronic disease management, integrative approaches to patient care, and the use of a shared decision-making to engage patients in self-care. And it's really my pleasure today to have Dr. Sarah Campbell speak to us about the 3Ds.
Thank you very much. And it's lovely to have such an intimate crowd today, because that means that we get to share stories, and sometimes a small crowd is wonderful for that. And we can talk about cases and share even personal examples. One thing I will say, just a little bit about myself, what brought me to geriatrics and really to my nursing journey is oh, the alphabet soup behind my name. Yeah, Doctor of Nursing Practice. So rather than having a research doctorate, I have a clinical doctorate. So a DNP is a Doctor of Nursing Practice, and this is more a clinical focused doctorate. So thank you for asking. And then of course, family nurse practitioner, and I'm a certified family nurse practitioner. So thank you for asking about the alphabet soup behind my name. That's a great question. So I do see patients clinically on campus here as a family nurse practitioner, but I also teach as a professor as well. So I get the best of both worlds. But a little bit about my nursing journey. You know, as a child, I was brought into, as a family, we cared for my elderly relatives, and we weren't shielded. You know, as kids, we were brought into the hospital. So when I had sick and elderly parents who had diabetes and heart failure and rheumatoid arthritis, we weren't shielded from it. And I got to participate in care, and I got to help them with, I had a grandmother with COPD, and she was advanced, and I got to help her with her oxygen tank. So as a 4- and 5-year-old, this was normal to me. Caring for older adults was part of what we did as a family. And I think that experience was very special to me. And I think that, as a child, I really became compassionate watching my parents care for our elderly family, and they lived with us. And so it wasn't, it was a part of kind of our daily lives. And that really has just been a part of my own experience. And not every child gets to experience that. But, we were brought into the hospital, we were brought into part of their care, and I got to help them. And I think that's really what brought me into nursing and brought me into my passion about caring for older adults. And in my practice prior to coming to Irvine, I got to care for families. So I got to see grandparents and great grandparents and the teens and the adults. And I loved seeing that family dynamic and learning about how they all interact together. And that relationship with families really was a part of what I loved about, being in internal medicine and practicing, with geriatrics. So I'm really excited to be here today. Next slide, please. So just to review our objectives, today we'll talk a little bit about the differences between delirium, depression, and dementia. And really in older adults, it's important to define the differences because they do overlap and can really look very similar. I want to evaluate the common causes of delirium and strategies to address it, because it's important to not only recognize, but as people who are involved in touching geriatric community members and clients, we need to be able to recognize it quickly and act quickly because it's an urgent situation. We want to identify methods to communicate changes in condition to our team members, because communication about these changes are very important. And then review ways to recognize signs and symptoms of depression. Obviously with COVID, this has become the utmost important. So this is important for our members of our team even, and members of our friend groups and our family members. We need to check in with each other. We'll discuss approaches for de-escalating confused and agitated clients. So those with delirium, depression, elderly clients that have cognitive impairment can become agitated. Let's talk about how we de-escalate them. Next slide. So thank you for being a part of taking care of geriatric clients. We're all in this together, so I hope that you feel like we're a part of your team and we're all team members. We are, as we move forward, Orange County, our efforts are to become dementia friendly and really take care of older adults who suffer from dementia. And, as a part of that, you're a part of our team, so we're happy that you're with us today. Next slide, please. One of the things that I'd like to discuss quickly is when we talk about caring for older adults, we use a framework called the 4Ms. And today, really, we're going to focus on not only the mind, but even medications and how can medications really affect our geriatric clients, older adults, and how they act and how they might look when they're presenting in front of us, whether there increases their risk for confusion or falls and that type of thing. So that's what we're focusing on today. Next slide. So delirium, let's talk a little bit about what is it, what causes it, and what we can do about it. So delirium really is caused by a medical condition. It's either a medication, a substance, withdrawal from a substance, or an illness or acute infection, or even an electrolyte imbalance, like a diabetic having a sugar that's too low or even too high. These changes can't be explained by other reasons, and there might be a change you'll notice in attention. So it's a sudden onset, a shorter period of time. So this is a change that happens pretty quickly. It's going to happen either overnight or in a period of hours or weeks. It's not something that's going to be long-term. So it's a little bit different from dementia. They're unable to focus their attention, and there may be decreased awareness or heightened awareness. So they're awake, in the middle of the night when they shouldn't be. There might be a change in cognition, meaning how they think. They might have some memory loss or confusion, disorientation. They might have difficulty talking or speaking or understanding and having changes in perception, even hallucinations. And how this plays out is you might see changes in behavior. They might become agitated or have emotional, outbursts. And so delirium is really an acute or quick onset. And so when we see things like this, we need to figure out what's the cause, what just happened to make them change suddenly. One of the things that we see happen is this will happen when someone's hospitalized. They have an acute illness like pneumonia or something happens, they get put in the hospital, and all of a sudden they get very confused. They were fine before they were admitted. They go into the hospital, and within 24 hours, they're very confused. That's delirium. We see this happen with people when they're put on medications. So let's look at the next slide. Let's talk about some of the common things. So medications is a really common one, especially in older adults. Things like Xanax or sleeping pills, hypnotics, antipsychotics. So pain medications, right? Something like Vicodin or Percocet that someone like you or I could take might affect us normally, but someone that's older, they might get really confused and disoriented, and it might cause them to be delirious. Believe it or not, really severe pain can cause delirium. Electrolyte imbalances we talked about, but also dehydration. So someone that comes in that's very sick and they become suddenly dehydrated, they can become very confused. And then infections like a UTI. So we see this in older adults when they get a urinary tract infection or they get pneumonia or even COVID, right? More relevant. When they're not eliminating well, so they're not urinating or they're not, having bowel movements normally, this can really affect their fluid balance and their electrolyte balance. And then when they're not eating as well. So some of these things are reasons that they could have an acute change in their behavior or their ability to think straight. So these are some of the things we want to watch out for. Go ahead and go to the next slide. So if you can, just think about, even if you can't think of a client, think about a family member that you might have seen this happen to, that might be frail or might have some chronic illnesses. What are ways that, thinking about some of the common causes, you would prevent them or might help prevent them from having delirium? So in the chat box, if you don't mind, since there aren't that many people here, maybe type in the chat some things you could do to prevent delirium, thinking about some of those common causes. So if you don't mind, just type an answer in the chat box. Great, pain management. So managing their pain well, encouraging fluid intake. That's an excellent one. Believe it or not, the drive for thirst in older adults tend to go down, so they might not remember to drink. They might not feel as thirsty as we do. So you might have to remind them. That was great, Allison. Anybody else? Sleep. Great, Elaine, that's excellent. Believe it or not, going without sleep can really cause delirium. Check the number of meds. Yes, I agree. So being on too many medications, looking at medications is probably the number one thing we should do first, right? A review of their medication list. Are we doubling up on something? Are we causing low blood pressure? Are we, do we have them on, something they shouldn't be on? Great. These are great examples. Next slide. So some other things you can do, observe their usual behaviors. When we know our clients, when we know our family members, when we know our patients, the better we know them, the more likely we are to notice a change quickly. So once we know our clients the best, then we can notice a change. Encourage and engage conversation. If they seem confused, probe a little bit, kind of engage them and talk to them a little bit, get a sense of what's going on, engage them in conversation, try to probe and explore what's going on, and encourage meals and hydration, especially, this is where you guys come in with Meals on Wheels. This is why it's so important, the service you provide. Alterations in taste and, again, lack of thirst may affect appetite and drinking habits. So this becomes really important. And eating is social. One of the things I think we forget is to offer to have a meal with someone, right? So just offering to say, hey, can I take you to lunch? Can I sit with you and eat this meal with you today? And then listen to some cues. So if clients are mentioning I'm on a new medication, or, I've been in so much pain, or, I'm not really feeling well. My stomach is just not good these days. I'm not feeling well. Those are things to notice and pick up on. And those are times that we might need to communicate a change. So even if you're hearing this from a family member, a client, encourage them to call their doctor, encourage them to call a family member, right? Report up in the chain of command. So whatever avenue you have to report, we want to encourage the client to report that symptom, talk to a family member and report up in the chain of command. Next slide. So bottom line, as a team member, you can make a difference. You can save a life. So pick up on those sudden cues, little nuances and differences in behavior. Ask them how they're doing. Ask them, tell me, what is today? Ways you can check on orientation. Do you know what today's date is? What was yesterday? What did you do yesterday? Kind of check in and see if they seem a little confused, and then remember to report a change. If you know of the family member or the emergency contact, give that person a call. Say, I've talked to your mom today. I've talked to your son. They seem a little bit confused. Have you noticed anything? So report that change to someone. Make sure that you're communicating up the chain of command as well. Okay, next slide. So depression, let's talk a little bit about how we define depression. Depression really is defined as 2 weeks or more of 5 or more of the following symptoms. So either a depressed and sad mood, someone not enjoying things that they previously enjoyed. That symptom is called anhedonia. So when they say, I'm just not, enjoying, or they're just not liking the things they used to enjoy, not doing the hobbies or liking the hobbies that they used to like before. Having insomnia or hypersomnia. So they're either not sleeping well or they're sleeping too much. Those changes in sleep patterns. A change in appetite or a change in their weight. So losing weight or having no appetite or eating too much. Having slow movement, so moving really slowly or being real agitated. Having low energy or poor concentration, or thoughts of worthlessness and guilt. Other things to pick up on would be recurrent thoughts about death or suicide. Obviously, these are very, alerting or alarming symptoms. And the cause of this really is a neurotransmitter dysfunction. Our brain's not using enough of that serotonin, norepinephrine that's available there. We're not using the neurotransmitters in our brains. And so that's the main cause. But it has to be at least 2 weeks or more of 5 or more of the following. Next slide. Depression is not a normal part of aging. So I often would hear this in my practice, this is just getting old. oh, I'm just tired. Oh, normalizing the symptoms. Oh, this is just me getting old. It's all downhill from here. And really, that's not true. Depression is a treatable condition. It's a disease just like any other disease, like diabetes or hypertension. It is treatable. The severity of depression is significantly higher among Black, Hispanic, or other race groups compared to non-Hispanic whites. And depression is more common in people who have chronic disease. Now, when you think about who has chronic disease, 60 people who are 65 years or older, 80% of 65 years or older have at least one chronic disease, and 50% have 2 or more chronic diseases. So older adults is the population who is at high risk for depression, believe it or not. And older adults are often misdiagnosed or undertreated because, again, we're downplaying the symptoms and attributing that to, oh, that's just your aging. Oh, that's just your diabetes. Or, of course, you're going to be tired. Of course, you're going to have appetite changes. Of course, you're not going to enjoy those things because of yada, yada, yada. We kind of excuse it away. So we really need to pay attention to some of these clues that we're getting that that patient or client might be depressed. Next slide. So what does it look like? So signs are things that we can observe from the outside, and symptoms are things that the client would tell you. So things that we can observe, the client might look more withdrawn. They might be refusing or not participating in care or normal activities. They might be crying, or they might be irritable. They might have a flat affect. So a flat affect would be something where they're kind of just staring. They don't really have much of an expression. Maybe their voice is somewhat monotone, and might be unfocused or not really making eye contact, kind of staring off into space, not really engaging in that good eye contact. Excessive sleeping is another thing to look for. Symptoms would be things like reporting appetite changes. Oh, I'm just not hungry. Feeling sad, down, or hopeless, expressing that. Saying they feel tired or fatigued, and expressing they just want to go to bed again. I just want to go back to bed. I just need to take a nap again. Trouble sleeping. So they're wanting to sleep, but they're also having trouble falling asleep. And then again, lack of pleasure or lack of enjoyment in doing things that they normally like to do. Next slide. So what can we do? What can I do? Notice and ask. So, open versus close-ended questions. When we ask things like, are you okay? Yes. We don't get much information, right? So it's better to ask some of those open-ended questions. So things that we can ask, how has your mood been? That opens up the opportunity for them to describe and tell and engage in a conversation. This has been a really tough time. How have you been adjusting to all these changes, with the pandemic? I noticed you've seemed upset. Are you feeling okay? Can you talk to me a little bit about your mood? Have you been feeling hopeless, sad, or depressed? Now, this question in particular is one that's specific to some of the screening tools we use in medicine to screen for depression. I've noticed you haven't been smiling as much as usual. Is something bothering you? You want to tell me about it? Or have you lost interest or pleasure in doing things you normally like to do? And sometimes I notice that it helps if I don't say the word depression, because I think there's still stigma surrounding the word depression. And sometimes I find that with some older adults, if you say depression, they kind of shy away. But if I use words like, are you feeling sad? How's your mood? Have you been, a little hopeless? Have you felt guilty? Some of those other words are more likely to express that, yeah, that is somewhat what I'm feeling. So it might be good to use different language sometimes. If they answer yes to any of those questions or indicate they're feeling sad, having mood changes, they may be depressed. So this is, again, something to report or something to, report up the chain of command. Next slide. So again, knowledge is power. You can make a difference. One of the things I encourage you all to do, if you haven't investigated this, is here at UCI and all across the country now, there's training called mental health first aid. So to become a mental health first aid provider, there are some courses out there, and it's just like you would come across someone who has gone into cardiac or respiratory arrest and give CPR. This is like first aid for someone in a mental health crisis. So if someone says to you, I just want to commit suicide, or I'm having suicidal thoughts, and we don't know as lay people what to do. Sometimes even as a nurse, I wasn't trained I wasn't given the language. We were told to call 911. I've been told how to screen for depression, but then what? What are the words you say? How do you help someone in that situation if you're on the street or something happens and they're in a crisis? So these courses are great to give you the tools and the words of what to say. So mentalhealthfirstaid.org, you can take these courses in a group, or you can join another group locally. So I encourage you to check out that resource. Okay, next slide. So activity on what you would do. Let's just pause for a second. So just consider this. You observe Mr. Juarez has come to the door, and this might be more appropriate for a driver, or maybe you're having an interaction with the client. He comes to the door in his pajamas and he appears like he hasn't showered in many days. You've noticed over the past several weeks he seems sad and is not making eye contact or joking like he usually does. You're worried about him. He's usually very well dressed, clean, and smiling, and he usually makes eye contact and engages with you. What questions would you ask to find out if Mr. Juarez is depressed? So in the chat, just pick a question. What could you ask him to find out if he was depressed? Or you can unmute yourself. Yes, how has your mood been lately? That's a great question. And it's very non-threatening. I think it's a kind of a generic question. Hey, how's your mood been? Anybody else?
So may I ask a question about that?
Yes, absolutely.
Is it better to say something like, how's your mood been? Or is it better to say, or is it all the same to say something like, you're usually always making a joke when you open the door. I noticed you haven't been doing that recently, to try to make them think about a happier scenario.
You can do either. And sometimes if I find that if patients seem to be in denial, I'll point out a behavior. I'll say,
Okay.
The reason I ask
Yes.
is because, and I'll point out what I'm noticing, and I'll say, and I'll express my concern. I'll say, I'm worried about you. Usually you're telling jokes and I notice you're not like that. So are you okay? I'm concerned about you. So I point out, especially if they say, no, I'm fine, because that's the typical answer we give, right? We all tell each other we're fine. We do that a lot. We've done that a lot during the pandemic, and we're not fine. Behind closed doors, we're suffering. Our kids are suffering. Our family members are suffering. And I think the I'm fine answer is just, sometimes we got to cut through and we got to say, I'm going to ask you because I've noticed, you're usually not in your pajamas, you're staying in your pajamas, are you okay? I'm really concerned, especially if you've got a relationship with someone, it's a little easier to kind of step into that space and just say, here's why, and be honest with you. Tell me, are you okay? And that's why some of those other questions, I find that sometimes if you say the word depression, some people don't respond well. So I like to give you lots of other language. Like, how are you feeling hopeless? Are you feeling, how's your mood? And sometimes that will get them talking. Sometimes I ask, are you depressed? You seem depressed. So it just depends on the person. That's a great question.
Thank you.
Yeah. Okay, next slide. So speak with your clients, ask them how they feel, listen carefully and watch for those behavior changes. Sometimes it's a slow, subtle change, in deterioration, but really talk about death. This is important. I can't reiterate this much, or enough. And I think this is an important thing to touch on when we're talking about older adults and, and especially coming out of the pandemic, the social isolation has really, really affected this population the most because of the risk of, COVID. So listen about talk for death. Everyone would be better off without me. Things like, I think I should just end it all. Or if I weren't here, my family wouldn't have to be going through all this. This is a really common one I'll hear in practice. I'm such a burden to my family. I just wish that, things like that. If I just took all my meds at once, I could just drift off to sleep. A common misconception. When you notice changes, ask them how they're doing. If you suspect they're depressed, notify a team leader. If you hear thoughts of suicide or self-harm, of course, we should notify someone immediately. Typically what we've done in the past is call 911. One encouraging thing I'll let you know, and Julian, we've talked about this, and this is something that, we've recognized that, unfortunately, mental health has been criminalized at times. And when we call 911, it's not always handled in the best way, because who comes out is police or, and so 988 is going to become the new 3-digit mental health crisis line. So an alternative to 911 will be calling 988. And this will get you to mental health support services where you can call and you'll be directed directly to people who are trained for these type of crises. So this is supposed to go live in July 16th is the date. Currently, the National Suicide Prevention Line, of course, we've had this line for a long time, is 1-800-273-TALK. But I have a resource on the last page for, if you want to read more about the 988 line. NAMI is a great organization, national organization for mental illness. And you can read about kind of the legislation and the power behind what's driven this, but that's when it's supposed to go live. And that's encouraging. It's great to know. But again, that mental health first aid, becoming a mental health first aid provider is also very helpful if you'd like more tools. Next slide. And Allison, you mentioned ask him what he has done yesterday for plans for today. I think that's a great way to kind of check in as well. So dementia, we're going to move on to dementia. And dementia really is the difference between dementia, depression and delirium. Delirium is, more of that sudden onset. Dementia is a slow progressive onset. So it's a decline in one or more cognitive areas, either with learning and memory. So in other words, recalling some words. I were to tell you, remember these 5 words, and 5 minutes later, I ask you those words. Are you able to learn and recall those words? Complex attention, can you sit and do math, subtract sevens, from 100, serial sevens, right? Language, speaking complex sentences, visual, spatial, drawing a clock and setting the arm to a certain, number, and then executive thought. And so complex math problems. It worsens over decades typically. So this isn't something that necessarily is going to worsen overnight. However, dementia patients can still have delirium. So you can have dementia and then have delirium on top of it if something were to happen suddenly. But it's a slow progressive, and you can have mild dementia, moderate dementia, or severe dementia. You may again have a sudden progressive if there is an illness or another disease on top of it. There are many different types. Alzheimer's, of course, is the most common. There's vascular dementia after a stroke or trauma, frontotemporal lobe dementia, and then other dementia, infectious encephalitis or Lewy body is another common type of dementia, Parkinsonian dementia. And there's all kinds of different types, but the one we're most familiar with, of course, is Alzheimer's. Next slide. Dementia disparities, by 2060, 14 million people will have Alzheimer's, and Hispanics will be the population group that will increase 7 times today's current cases. So the rise with Hispanic population will be the biggest increase. African Americans will increase by 4 times today's current cases, and then women are 2 times more likely to have Alzheimer's than men, and all minorities experience greater challenges because of access and receiving quality care. So this is something to really pay attention to. And this is where, our efforts really need to be, concentrated on is access and serving underserved populations. Next slide, please. So when we think about dementia and how it affects cognitive thinking and abilities, how can it affect activities of daily living? Well, we can think about the fact that it becomes more complex and more difficult. Therefore, things like just showering, things like being able to, do grocery shopping, driving, remembering how to turn on and off the oven, remembering to do that. Short-term memory is the first to go. And so remembering that you turn the oven on and forgetting to turn it off makes the fact that just doing daily living tasks like feeding yourself, cooking, shopping, driving a car becomes very dangerous at times. And so these are patients that have, risks of injury and accidents, things like, forgetting to eat, forgetting to drink, and needing much more assistance. And then the fall risk is much, much higher. So these are things that we have to think about for our patients with dementia and why they need, functional screening and comprehensive screening when they come in for care. Next slide. So creating a dementia-friendly environment is something that's very important. And these are things, of course, we think about with our community members, but also if any of you have family members that have dementia. Know which clients, of course, have dementia. Maintain the same delivery routine is very important because changing a routine can vastly, confuse them. If they're already confused or have memory issues, once we change a routine, that can really throw them off. Being aware of sundowning behaviors. And this is where some of our patients with or clients with dementia can get more confused during the evening hours. So it's really helpful if we can know which patients can become more confused during those times. Have a cheat sheet with likes and dislikes. Know which clients prefer to go by a certain nickname, know their routine. That way, when you engage with them, you really get to know them well. And share that with other drivers, share that with other team members so that they feel well known and you do know them well. And remember, they may require the use of assist devices. So, try to be patient, don't get frustrated. They may have hearing aids in, but they might not have batteries in the hearing aids. So really be aware of their own needs. They might need, their dentures in, their eyeglasses in. So these are things that we can do to just keep in mind and be aware and help them with. And dementia friends, if you want to become a dementia friend, you can go on to this website and become a dementia friend. And this is, again, something we're pushing for in Orange County. And you can do this as a group or do this individually and actually get a certification here to become a dementia friend. So it's another training, and this can be done online as well. Next slide. So some triggering events, things that might trigger or escalate a client that has dementia. And that would be, again, something like a change of environment, having a new roommate, changing locations, moving, something happening in the home, new construction, changing of a routine or a new way of doing things really can throw them off. An illness and infection or being uncomfortable can really make them agitated or trigger them to escalate. A new medication, so having a change in a medication or a change in a dose, increasing or decreasing a dose. And then disease process. So usually people with dementia don't just have dementia, they often have other chronic illnesses. So if that other illness is out of whack, that can affect the dementia and make the dementia seem worse. And then sights and sounds, odors, sensations, things that are annoying, beeping machines, beeping IVs, construction going on down the street that's beeping, loud noises, sudden noises. And then changes in food menu or even a delivery time can actually kind of trigger them or might be, something that would escalate. So things to think about. Next slide. So some de-escalation strategies, always be non-threatening and reassure the client. Let them know they're safe. So if you encounter a client that's in an escalated, triggered state, use a calm and even voice. You want to smile, support them. They might feel scared or endangered or in fear. Typically, that's the emotion that's going on. And what they're doing in that state of agitation is not personal. It's not about you. It's about the emotion they're feeling. Keep things simple. So with dementia patients, you actually want to ask close-ended questions. So are you okay? Are you in pain? Are you cold? Yes or no questions. So keep things very simple. Only one person speaking to that patient or client at a time. So don't have multiple voices or multiple people trying to walk towards them, act towards them, be talking to them. That just confuses them. Multiple voices gets them more escalated and triggered. And then try to identify the trigger. Remember what happened right before that client got agitated, what's going on, and remove them from the trigger or remove the trigger from them. Try to identify it and use or distract doctor suggests something new. For instance, if you know you have a client that likes to go look at rose bushes, suggest, hey, I know you have lovely rose bushes. Do you want to go show me your rose bushes? I'd like to see how well they're growing, and kind of use those distraction tools. Are they in pain, hungry, comfortable, uncomfortable? What need do they have at that moment, and how can we meet the need? And then don't challenge, accuse, or argue. There's no point in arguing or reorienting them to what you think they need to, the place they need to be at, right? So consider the feeling behind their words. Don't take it personally, rather than what they're actually saying. They might not be making sense, but there's a feeling behind the word. So what's the feeling? Is it fear? Is it pain? Is it discomfort? Is it anger? What are they feeling? And try to validate the feeling and then address the issue. Next slide. So let's share our stories, and I can share one, but I'd love to hear from you. Is there a time when you've ever encountered a client or even have had a family member that was really confused or very agitated, that maybe has dementia or had dementia? How did you approach them, and what did you learn from the situation? Does anybody have an example? And maybe you handled it well, maybe you didn't handle it well. How would you handle it differently?
I was just going to make a generalized comment that I think one of the issues with family members is that it's so frightening if you see a family member who is in one of these stages of upset or decline, that we as family members really need to learn more about how to take care of our older family members.
Yes.
And I think that's a really important thing. I also am this is sort of different, but I'm interested to know what the screening is in a geriatrician's office that would help. I mean, I know there is screening that for all of these things, and I know they help. How could we make that available to more physicians, or convince more physicians that this is really important? Because I know even there's so much that's dismissed in a doctor's office merely because of the time constraint, the payment situation, and a lot of things we take for granted. And this is not anything about dementia or whatever, but a friend of mine went for her regular gynecological exam, annual, and she's in her late 70s, and the doctor said to her, you don't need to have a pap smear anymore. Well, that's not right. Just because she's old doesn't mean she doesn't need a pap smear. You know what I'm saying? It's like we seem to have developed a system as a society that we make certain assumptions, and they're mainly based on our lack of knowledge around things. So what is a way that we could make that different?
That's a great question. I think what's helpful is when I always appreciated when family members told me, here's what's going on. I have a concern about the memory. And can you perform a test, or, here's my concerns about memory. I would always screen when memory, when family members, or even when patients said, I feel like my memory's not good. I didn't need it to be a family member. If a patient or a family member brings a concern about a memory and says, can you please screen? There's no reason not to. The tests and the screening that we do, even just the cognitive screening test that we do, take a matter of minutes. So anytime a family member advocates, and sometimes what's helpful too, is to schedule the appointment for that reason. In other words, when you call, don't wait till the physical, the annual exam. Don't wait for the time when you're going to go in for maybe another thing. Schedule the visit for that reason. Say, I'd like to come in because I want to address my husband's memory, or I want to come in because I have concerns about my memory, and make an appointment for that reason, because that way you have a dedicated appointment for that time. And then if the provider is kind of trying to dismiss, or, if you get that kind of feeling, give examples, write down some notes about what you're seeing. That's always helpful. I appreciate it, because I want to know from that's really good knowledge on my part. And sometimes too, I know that families are concerned about bringing it up in front of the patient or in front of their family member because the family member is in denial, right? So you might pull the provider aside or call the provider in the hallway and say, he's going to deny this, but here's what I'm seeing. I'd take a note. I would love the family members to tell me ahead of time, because they would tell me, he's going to deny this, or he doesn't think it's a problem. Here's what I'm seeing. Slip me a note and I got it, because that's understandable. So advocate and make an appointment for that reason,
Thank you.
Dr. Sagal probably has some other great, wise, sage advice too, but I think you're being concerned about memory is something that any provider would take seriously if you brought that to their attention. But I think making a dedicated appointment to address it is my biggest advice.
Because we don't want to address it, right?
Well, we should, we should.
I know.
And many of us do screenings like I do, many of us, and Dr. Sagal does, we do screenings as part, even if it's just as part of our normal exams, even for memory. But if you have outside of that time, if it's not being done, or if you have a separate concern, make an appointment for that reason.
Yeah, because you have that point of view, but it just seems like if it's very easy, and I don't know if people, if there are questionnaires, for instance, a patient could fill out in the waiting room, 3 questions, and would that help or whatever? Just the point being, I hope more people learn about how to deal with these things.
Yeah, and that's why we want to become a dementia-friendly county. This is why. This is exactly why. One example I'm going to give is that we had, and this was a great one that I love that was brought up by one of the members at one of our other talks, was that there was a patient that was very agitated at one of the skilled nursing facilities, and she was super upset, believed she was on a cruise, wanted to talk to the captain because she was having a horrible experience, and she was adamant. And, rather than taking the time to tell her, no, you are here, you're at Brookdale, or whatever, you're at, and I'm just making that name up. I don't even know if there's a place called Brookdale, but you're at Brookdale or you're at Sunnyside, today's date, you are not on a cruise. Rather than doing that, she said, I am so sorry you've had that experience. I'm going to go talk to the captain right now. Could you tell me what your concerns are? And she pretended to write them down and take them to the captain. And the patient was absolutely thrilled with that response and thought, thank you so much. You've taken my concerns. So, the point being that rather than you go along with the delusion, there's no harm in going along with it. You don't try and reorient them or argue or tell them, no, they're wrong. They're not on a cruise. They're in this situation, because they're going to forget in 3 minutes, especially if they're severely demented, and you're validating what they're telling you. And there's no harm in validating what they're telling you. So I think the old way of learning was reorient, tell them where they're at. There's really no reason to try and force them into our realm when there's, when it's okay to kind of validate their concerns and get to the feeling, right, rather than what they're saying. And that's the point here. Later on, if you guys want to check out this great YouTube video, is one done by Teepa Snow, and she does a lot of training for demented patients. And it just shows her an example of what she did with a demented patient who was being approached and kind of attacked by all the EMS personnel, and it was a demented, agitated patient. So you can always copy and paste that. I won't take time to do it now because we're running out of time, but next slide, and we'll get through the next couple. So just a couple reminders. Do remember to introduce yourself, but don't confront. Smile, but don't argue. Always stay relaxed, but don't correct. Move slowly and distract, but you don't need to remind or reason. There's no reasoning with demented patients. Always describe what you're doing. Don't come at them and do it. Describe, ask permission, let them know, and then get to know your client, but don't demand, force, or rush them. Understand your client's perceptions and feelings. Don't raise your voice or show alarm. And then gather information, know their interests, their nicknames, who their family and their pets are. Manage their behavior by using their client-specific interventions, what's important for them, but don't restrain, grab, hold, or touch them, especially when they're in an agitated state. You give them space, but you show them that you're on their side, and always offer reassurance and validation. Next slide. So these were supposed to be animated. So these are just, I was going to test you, but we'll pass this. But anyhow, so I'll give you guys a chance to ask if you have any questions about the content. And then I think we have a case we're going to review, Daryl, that you had brought up, right?
Yes.
Okay.
Yes. Well, I just want to say, I think this has been so helpful. And I believe that the more educated we are, the more likely we are to be able to handle these situations. And that's the point, is to handle these situations with care and dignity, and the fact that you've reinforced that it's important to know the person and how to connect with them. I just am so, Meals on Wheels is such a shining example of that, right? Of just knowing when the client is not in the right place.
Okay, exactly.
So knowledge. And so
That's
really
right.
thank you for sharing all your knowledge with us. It's great. And these resources are wonderful about the trainings. Thank you.
You know what, if you want to go to the next slide, I wanted to show the next page, the one after that. Yes, these, so there's the Alzheimer's OC, and they're great. There's also support on caregiving and daily communications. That's for caregivers. Depression facts for older adults, but dementia friends, and then also the crisis advocate line. But the mental health first aid is also important. But Alzheimer's OC, there's a 24-hour line. If you're ever in an agitated state with a family member who's demented, you can call them 24/7. They have a crisis line. So if you don't know how to handle a situation with a demented patient, you can actually call them. But that's on the Alzheimer's organization website. So there is a line there, because you mentioned.
I would love to post some of these on our Meals on Wheels California website as resources. I think that would be very helpful. Are you good with that?
Yeah.
Great. Thank you.
Thank you so much, Dr. Campbell. Does anyone have any questions for her?